Oh, okay. I was hoping to be able to blank it, but you can't. We'll just rush past it. Okay.
Good evening, everybody, and welcome to tonight's forum. It's great to see you all here at Robinson College, and I know we've got quite a few people watching via Facebook Live as well, so from all around the world, which is really fantastic. It gives me great pleasure to introduce you to Dr. Ed Barnard, who is an expert on traumatic cardiac arrest and is going to be giving us lots of information and sharing that expert knowledge with us all. So I hope you enjoy it. Thank you, Ed.
Thank you. Good evening, everyone, here and also those people at home. And thanks to Adam Chesters for the invite to come and talk today. I'll just quickly skip over the first couple of slides. My Twitter handle's at the top right, in case you want to engage with me after this lecture. So let's take a little macro look at what I'm going to talk about today. So we know that the practice of medicine is really complex, and in part that's due to the natural variation of our species. It's also due to the variation in response to illness and injury, and also due to our human mind's preference for laziness, which probably results in oversimplification of lots of the processes that we do. And cardiac arrest is a really good example of this. So historically, and probably now as well, we assign a single term to a whole collection of disease processes and then try and manage every case with one simple algorithm. Of course, normally in cardiac arrest, we haven't really got much time at our disposal, and so we need to have some sort of immediate action that we can do, and that sometimes gets us a bit unstuck. So in medical cardiac arrest, you can be assured that chest compressions are really good immediate action, a kind of holding pattern, while we work out what we're going to do to try and make the patient better. But we're still in the process with traumatic cardiac arrest of even recognising that it's completely different to medical arrest. The definition of TCA itself can often be an oxymoron, in that in a subset of patients, the heart is still beating and there's still cardiac output, but we still use the term cardiac arrest. And we're also only recently discovering that chest compressions, which are the kind of the gold standard immediate action for medical arrest, might be detrimental in some groups of patients, but we've got no agreed way of differentiating in which patients chest compressions might be indicated and in which they shouldn't be. And furthermore, owing to the complete lack of total epidemiological data or an understanding of all the patients with traumatic death or TCA, we're a really long way off having an understanding of how this complex disease process works, which is really crucial if we hope to improve outcomes in the future. And moving on from that, in this era of endovascular resuscitation, it would be really remiss of me to not mention things like REBOA, SAP, and extracorporeal life support. And that's, as you probably know, is an area that is not devoid of controversy. So in this lecture, what I want to do is give you a deeper understanding of traumatic cardiac arrest through discussion of some of the evidence and some current concepts, looking at a few made-up cases. And I'm going to then follow with a review of the complex decision-making and the current state of play of endovascular resuscitation. So I've shaped this talk, obviously, from my own mind, so it's the world according to Ed Barnard. So it might be useful to know a bit of who I am. So I joined the Navy at medical school almost 18 years ago now, and after house jobs embarked on a 4-year period of not working in hospitals, which won't surprise some people in the audience. And that was around the world, working in remote and austere environments, often in the Arctic, Antarctic, the South Atlantic, and at the end in Iraq. I then followed that with some training in the West Midlands in Birmingham, where I was lucky enough to be part of the West Midlands care team, doing some pre-hospital care, and also started getting interested in research. I then moved down to Bristol to do kids, and then down to the southwest for further training, and some more sort sort of small projects in research, and then a deployment to the UK hospital in Afghanistan. And on return from that, I was selected to do a PhD with the US military in San Antonio, Texas. And that PhD was centered around the current and evolving and maybe future management strategies for hemorrhagic traumatic cardiac arrest, really in recognition of the large number of UK and US service persons who had that injury pattern. So I'm currently assigned to the Royal Centre for Defence Medicine in Birmingham, but work here in Addenbrooke's Hospital in the Emergency Department and also with East Anglian Air Ambulance. And I've recently been appointed to the Academic Department of Military Emergency Medicine as a senior lecturer. So I have got a disclaimer, which unfortunately I've got no financial interest in anything I'm going to talk about. My views are my views and not those of UK Defence, and this presentation has been cleared by my boss. Right, so let's start off with a case. You arrive at this case, it's high-speed road traffic collision of a young person versus a solid object, a tree, with large deformation of the car. And your crewmate says to you, trauma is the leading cause of death in young people. Who agrees with that? Be bold. There's one, two, three people, four people, 5, 6 people. Okay, so a few of you. All right. So you've probably seen this before. This is the World Health Organization's publication, which shows that in their estimates, injury is responsible for more deaths than HIV, AIDS, TB, and malaria combined. And in the next about 11 years, they reckon road traffic collision will be the 7th leading cause of death in the world overall. Closer to home in England and Wales, it's the number 1 cause of death in those aged 1 to 35 years old in a published report. And that's about 5,500 trauma deaths per year. Some more recent data from the Office of National Statistics, who collect data on cause of death, looking from 1915 to 2015 in different age categories, so 1 to 4 through to 80 plus. What we see is a variation across the years. It's all colour-coded, and I'll explain the colours in a moment. Anybody want to hazard a guess what the green area is? That's infections, which then, of course, had antibiotics, and people stopped dying of that. There's a small group of cancer down here and down to the right as well. A large group of heart conditions. And this slide, I should say, is the male cause of death. The female is slightly different, with heart disease happening in the older age group. And we have road traffic collisions up here. And what you'll see from this graphic is that we sort of stopped having RTCs as the leading cause of death around about the mid-90s. And that's probably due to changes in legislation around seatbelt use and child restraint. And we see a move into this category here. And this category here is categorised by ONS as drug misuse, suicide and self-harm. So depending on the mechanisms of suicide and self-harm, trauma may still be the leading cause of death in young people, but its character has certainly changed in recent years. So moving on to case number 2, you get to this road traffic collision with some high impact and some high energy impacts. And your crewmate says to you that TCA survival has increased over the last 15 years. Who agrees with that? None of you. One of you. Okay. All right. So you can be forgiven for believing that, and that might be true. So if we look at some survival statistics over the last 15 years, so along the bottom you've got traumatic cardiac arrest survival from 0 to 12%, and you see ERC 2005 line there, and that's showing 2.3% survival. And that's the European Research Council guidelines from 2005. Did a really good job of putting together a bunch of research in the previous years and then synthesising it all together and giving you an overall statistic for the combination of that data. So a pretty poor survival. There's a publication from London's Air Ambulance by David Lockie looking at 1995 to 2005, which you've probably read, some of you, which showed a survival in traumatic cardiac arrest of 7.5%, so a really big jump. And the European Research Council guidelines in 2010, including data that was published between 2005 and 2010, then obviously shows an overall survival of 5.6%. If you look at those years alone, so 2005 to 2010, you can see a 9.7% survival, which is getting really close or exceeding lots of places' medical cardiac arrest survival. And then we did some work in the UK more recently with the Trauma Audit Research Network data for England and Wales over 7 years, showing a 7.5% survival. And they're looking at military data from 2003 to 2014 in Iraq and Afghanistan. showing a survival to hospital discharge of 8.7%. So you'd be forgiven for thinking that there's a trajectory of increasing survival in TCA in the last 15 years. But there are two areas at least that need consideration. And the first one is definition, and the second one is recognition. So let's start with definition. So this is a snapshot of the front of a paper from 1983, and they only included traumatic cardiac arrest patients who were in cardiac electrical asystole. So the heart was not beating anymore, and there was a flatline trace. And that showed a 2.6% survival with a 1.5% survival with good neurological outcomes, so pretty dismal. And that led to papers like this from Rosemurgy, which basically questioned the futility of pre-hospital traumatic cardiac arrest. And that may well have been a self-fulfilling prophecy. If you don't resuscitate these people, they will never survive, and the survival rate will be very, very small or zero. You're probably all aware of the European Resuscitation Council and their definition of traumatic cardiac arrest, which is this. So they make clear that it should be a clinical diagnosis, and it needs to be that to be really quick. And they have a definition that includes agonal absent spontaneous respiration and the absence of a central pulse. So that potentially includes a lot of patients who have something other than a flatline trace, a cardiac electrical asystole. So this is likely to include more patients, and importantly, the extra patients are less dead, i.e. they're the ones who are probably more resuscitatable or have more recently moved into traumatic cardiac arrest from a critical hypovolemia or another etiology. And this leads to higher reported survival. What we've also done in recent years, although some people are still coming around to the idea that not all cardiac arrest is the same thing, and deeper than that, not all traumatic cardiac arrest is the same thing, nor medical arrest. But we have a recognition now, I think, amongst healthcare providers that traumatic cardiac arrest is not always a futile situation. We hope to have an understanding that traumatic cardiac arrest is not medical cardiac arrest. And we also have hopefully had advances in trauma care that have also led to higher reported survival. Another really important factor is the data used by researchers who publish their work looking at traumatic cardiac arrest. So almost all of those registries worldwide start when the patient arrives at hospital, and therefore requires a patient to be taken to a hospital in order for them to be included in that registry. If we look back at the data we used from the Trauma Audit Research Network, at that time there would have been a proportion of patients who didn't meet any of these length of stay criteria because they didn't ever arrive at a hospital to be given a trauma number to be included in the database. So it's perhaps not surprising that we showed a pretty good survival to hospital discharge because we were using a cohort of patients who were likely less unwell than the ones who had already died and were left pre-hospital, which makes sense. More recently, we looked at 9,000 out-of-hospital cardiac arrests in the east of England, 2015 to 2017. Since I wrote this slide, this paper's been published in EMJ, so if you're really keen, you can go and have a look. And this research obviously includes patients who don't make it to hospital, so they're just pre-hospital patients, and also those who do. So it's a slightly broader look. And if we look at the medical and traumatic cases, it was predominantly medical cardiac arrest, which you'll be aware of. It's a much more common presentation. The trauma patients tend to be younger and more male. And there's an 8% survival, which is not significantly different to the rest of the country. And a 3.8% survival to discharge for traumatic cardiac arrest. Now, the problem with this number is that it's probably a more accurate estimation of the true survival of traumatic cardiac arrest, but it doesn't include patients in whom resuscitation was not attempted. So all the statistics you see about out-of-hospital cardiac arrest only include patients in whom the ambulance service attempt resuscitation, which is about 50% of those who make a 999 call for cardiac arrest. And it doesn't include those patients in whom nobody called the ambulance service because they'd been dead for some time. So in terms of evaluating causes of traumatic death, it's a massive overestimation. So we're not actually sure, but it's probably maybe even half of 3.8% is the true survival that we see amongst the whole population in the east of England. So let's go on to our next case. So you go to this case, and the patient is lying in the road And as you arrive at them, they kind of have their last breath and appear lifeless. So they've had trauma, they're apneic, and they have no central pulse. So by definition, they're in traumatic cardiac arrest. You go to start chest compressions, and your crewmate says to you, chest compressions are contraindicated in traumatic cardiac arrest. So you must have heard this multiple times. So let's go through some of the sort of basic physiology or mechanics of cardiac arrest. So I know that there are two theories, the cardiac pump model and the thoracic pump model. The cardiac pump model involves you pressing on the chest so the heart moves and blood is sucked in and pushed out. And the thoracic pump model is that you're moving the thoracic cavity up and down and therefore changing pressures and therefore moving blood around. And no one really knows exactly which one of these it is, and it's almost certainly a combination of both of these models. And the relative effect of each of them is almost certainly dependent on your technique, what's wrong with the patient, and all sorts of other factors. So we know that cardiac arrest is a really good immediate action in medical arrest. I've even seen dogs on YouTube doing it reasonably effectively. But what do we do in traumatic cardiac arrest? So 30 years ago now, a researcher called Luna looked at the effects of external cardiac massage or chest compressions in hemorrhagic traumatic cardiac arrest. So he used non-human primates. There's supposed to be 3 baboons, so there are 3 on your screen, good. So he took 3 baboons, and what he did was he bled them until their blood pressure was down to about, I don't know, what's that, 35 over 15? So likely to not have a palpable pulse. And then he started CPR. And what you see when you start CPR is the systolic blood pressure goes up, which makes us feel better, doesn't it, as healthcare providers? That's a good thing. But the diastolic blood pressure goes down. And that's really important because her blood supply through the coronary vessels to the heart is during diastole. So what you're doing effectively here is starving the myocardium of oxygenated perfusates when it needs it the most, and it's already struggling from having a very low blood pressure. So he stopped chest compressions here, and he gave the animals back some of their shed blood that he bled off earlier, and the systolic BP goes up, and importantly as well, the diastolic goes up. So what he showed by that was it's more effective in states of severe hemorrhage with some ongoing cardiac output to refill the empty baboon and therefore the empty human rather than doing chest compressions. A similar bit of work was done a few years ago by Jeff Coach in dogs, and he showed that fluids resuscitation was superior to CPR alone, and also CPR with fluid was superior to CPR. But probably the best bit of work's been done at DSTL Porton Down by Sarah Watson and Emrys Kirkman, which was published in the last few months as well. And they took 39 terminally anaesthetised pigs. They gave them musculoskeletal injury, which is important to make the model more translatable to real life. So they shot them with a captive bolt in the thigh to cause some tissue injury. And then they bled them and removed about 30% of their total blood volume, and then left them at a mean arterial pressure of about 40 to 45 for about an hour. And that's really important as well. So during that hour, the pigs are obviously becoming acidemic with increasing lactates and becoming sicker from their traumatic injury. At the end of that 60 minutes, they reduced them to a mean arterial pressure of 20 millimetres of mercury, so really very, very hypotensive, definitely in traumatic cardiac arrest. And then after 5 minutes, randomised them to one of 5 interventions. And the 5 interventions were chest compressions with a Lucas, blood, saline, chest compressions and blood, and chest compressions and saline. So what I want to do now, which is no good for people at home, but I'll let you know the results, is have a quick vote, either 1, 2, 3, 4, 5 with your hands, as to which therapy you think was most successful. Which requires everyone to put their hands up. Come on. Ooh. So there's quite a lot of 4s. There's a 2, I can see a 2, there's a couple of 2s. So 2 and 4 seem to be predominant. Anyone not 2 or 4? No? Awesome, thank you. Okay, so you think 2 and 4. So the ones with blood and chest compressions. Okay. So those who voted 4, we can chat about it later. So I've simplified the results for sort of ease of presentation. But basically, the best treatment overall was filling the pigs up with some blood. So their heart's still beating, they're still cardiac output, all they need is more fluid to be pumped around. The next best was option 4, so well done, I guess, almost all of you. I don't know why you want chest compressions, but maybe we'll cover that later. Next option is some sodium chloride, which some people say is only good for cooking pasta. Option 4, chest compressions and saline, and then the worst intervention, with some caveats, and I'm smoothing over the results slightly, is chest compressions alone. So if you give these pigs who are dying of severe hemorrhage chest compressions, surprisingly enough, they don't do very well. Right, so overall, where we think we're at with chest compressions so far on this talk, are that they provide lower survival than filling alone in hemorrhage. They slow filling down, so it's really hard to get a cannula in or anything else when someone's insistent on doing chest compressions. And also anyone who's used a Belmont or a level 1 infuser, particularly the subclavian line, and tried to give high volume blood at the same time, it just keeps stopping and alarming. You have to reset it and start it again. So almost no fluid goes in if you're doing chest compressions. They make the airway access way more difficult. They make ventilations more difficult once you have intubated or inserted nigel because you're increasing intrastatic pressure. So you've all been there where there's lots of air bypassing an nigel or making it difficult to ventilate the patient. And they also get in the way of chest decompression, so thoracostomy or needle decompression, and make it quite dangerous. They're likely to worsen thoracic injuries, so broken ribs, lacerating lungs, etc. You can imagine that. And they also increase the risk of injury to the rescuer. So once you're doing all these things, holding scalpels, blades, needles, whatever, and someone is, either someone or a Lucas is doing chest compressions, it's obviously reasonably dangerous. So we think probably sad face for chest compressions in hemorrhagic trauma. So let's go back to this case. So you started filling them up because you've insisted that you're not going to do chest compressions. And then the patient becomes bradyasystolic or asystolic. What are you going to do now? The patient was in a PEA initially. Don't all shout. I'll give you some options.
Some sort of systemic pressure at this point because you've got no cardiac output.
Yeah, okay, so that's a really good idea. So we probably want some flow, don't we? So we need the blood to go round. So I'll give you some options. So you can stop the resuscitation because the patient's dead. You can do some closed chest compressions, or you can do a resuscitative thoracotomy. Option 1, 2, 3. 2, 2, 2, 2, 2. So 2s, 3s. Okay. All right, yeah, good. So actually mostly 3s. Okay, so we could stop the resus, the patient's dead. So it's a really dismal outcome in traumatic cardiac arrest patients who are in asystole, particularly pre-hospital, and particularly without any more advanced intervention available. So at some point, you're going to have to make a decision, if this remains the case, of terminating the resus. Thoracotomy. So there's really dismal outcomes from thoracotomy in blunt traumatic cardiac arrest. So even the best data, I think the overall effect is about 2.3% survival, but it's probably a lot lower than that and isn't usually recommended. And by the time you've waited pre-hospital for someone to arrive who can deliver that procedure, it's extremely likely that it will be even more less indicated. Or closed chest compression. So as you said, chap in the black, we do need some sort of flow at this point, don't we? So we're filling the patient up, so there's fluid in the system, but what we're not doing is moving that fluid around with the blood. So you need some flow, and ideally this would be extracorporeal, so aortic arch perfusion or extracorporeal life support, which I'll talk about a bit more later. Excuse the Chad photo. So let's talk about this concept a bit more of where this patient's at. So this is a badly drawn monitor by me, and this shows a patient who has no palpable central pulse following trauma, so they are by definition in traumatic cardiac arrest. They've got a narrow complex tachycardia going at 146. they've probably got an ongoing cardiac output because the end tidal CO2 is 1.4, and if you had an invasive blood pressure, let's say, for example, it's 37/28. And this I would describe as a low output state in trauma. So kind of similar to medical cardiac arrest, pulseless electrical activity, but a different term to try and avoid the confusion between medical and traumatic cardiac arrest. Compare that to this patient who also has no palpable central pulse, so they're also, by definition, in traumatic cardiac arrest. And they're bradyagonal or asystolic, with almost certainly, 99% or more, they have no cardiac output. And this I'd term a no output state in trauma or a NOST. Now, of course, in medicine, nothing's ever this clear, right? So there's a crossover area, a grey area clearly between these two conditions. But in terms of conceptualising how you might manage these patients and what's happening inside them, these are probably useful concepts to think about. So, in no output state in trauma, you're going to control, which on my previous slides of this talk normally have brackets REBOA, so you could control that with something like REBOA, and fill the patient up. And there's every chance, looking at the animal model studies and looking at our basic understanding of what's happening with the patients, that the heart is still beating, there's still cardiac output, and so if you give more intravenous volume to that patient, they're likely to have a return of spontaneous circulation. And in young patients, certainly in young fit soldiers, from my limited experience, very small amounts of fluid can result in quite rapid changes. So 250 mils of fluid might be enough to bring them out of that traumatic cardiac arrest. Whereas in no output state in trauma, you're going to control and fill, but you really need to then consider flow. And the poor man's option is chest compressions. And that's controversial, but there's nothing else you can do at this turn unless you have some more advanced equipment with you. And of course, the evolving treatments that I'm going to discuss more about later is some form of extracorporeal life support. So some way of connecting the patient's circulation to an external pump and oxygenator that's going to pump blood back in. My point here really is that even hemorrhagic TCA requires more thought than simply following a standard algorithm. Right, let's go on to another case. So you just left the other job. You're driving down the road and you approach this T-junction and you watch a young guy on a bike crash relatively slowly into this car, comes off the front, knocks his head on the car, falls on the floor. You sigh under your seatbelt and get out and go and have a look. And he's in traumatic cardiac arrest with no obvious large injuries. You have options. So you can oxygenate, decompress and fill, which is kind of hot protocol. Do some CPR or something else. So once again, can I have 1, 2, 3s? Three, 1, 3, 1. Okay, so we've got probably about half 1s and half 3s, but no 2s? No 2s? Okay, were you guys here last month for Mark Wilson's talk? Yeah, okay. He'll be crying if he's watching. Okay, all right. So looking back at the time data that we looked at, the 7 years from England and Wales of patients in traumatic cardiac arrest, I have some unusual findings in that, which are probably some signal amongst the noise. And one of them was that we found a 15.2% survival to hospital discharge in isolated traumatic brain injury, which doesn't make any sense at all. We also found that chest compressions appeared to be associated with survival. So is there something else going on? And I'm simplifying things a little bit with those numbers, but that gives you an idea of some of the stuff that we found in the paper. So there is. This is Kramer, who about 130 years ago put forward the idea of impact brain apnea, which I'll just talk about briefly because I know it was covered in detail expertly last month by Mark Wilson. So this is a trace of an animal. It's a dog who's had a brass plate attached to their head and then shot with a .22 caliber short bullet fired from a pistol. Top line's respiration, the next line down is blood pressure, and there's a seconds time axis on the bottom. So the dog is hit in the head. You can see the respirations fall to 0, so it stops breathing. And then through cataclamium response associated with the traumatic brain injury or the injury to the brain, increases the blood pressure, which in some circumstances is enough actually to to cause a collapse of the cardiovascular system. With artificial respiration, that dog then starts breathing again and makes a full recovery. And if you want to read more about it, there's an excellent paper which summarises this concept and talks about a few cases in resuscitation. So, after a short reminder about impact brain apnea, we'll go back to our options. Can I just have a quick vote again? 1, 2, 3. 3, 3, 1, 1, 3. Okay, so we're kind of a mix of 1s and 3s again. Okay. So lots of patients in this scenario would get some sort of HOT protocol. That's our simplistic human brains really wanting a simple algorithm to follow, which is also needed in times of high stress and the need to do something instantly. What's the something else that people want for 3, by the way? Say again? So bagging through the apnea period. Okay. So this guy hasn't got, so he's apneic with no palpable pulse. So I'm slightly more heartened if you were thinking 3 to bag the patient through the apneic period, because that's correct. But he also probably needs some chest compressions to get the blood flowing around. So I'll go with option 2. So the patient needs oxygenation and flow, and without it, they're likely to die. So there are an unknown number of patients who record as traumatic brain injury in registries who have some sort of hypoxic insult seen on CT, who in fact are likely have had some sort of impact brain apnea. So moving on from that, your crewmate says to you, the management of impact brain apnea relies on the skills and knowledge of EMS. That may or may not be true. So if we look at some TCA response times in the east of England from the ambulance service and HEMS, so ambulance service in green and HEMS in red on the right-hand side. This is a random collection of patients. You can see the median response times are 11 minutes for the ambulance service and 27 minutes for HEMS. So if you're relying on either the ambulance service or HEMS to bag you through the apneic period, they're going to be sorely disappointed. If you look at a 5-minute response, that's less than 8% of patients within 5 minutes. And assuming that you're using oxygen at a normal amount, then you've probably got 2 to 3 minutes worth of oxygen in your lungs on a good breath before you become hypoxic. We found something else interesting in our data from the east of England. So there were 304 traumatic cardiac arrests. And you'd expect patients in traumatic cardiac arrest to have a non-shockable rhythm, so either in like a PEA brackets lost, if it's hemorrhage, or in a bradyagonal or asystolic rhythm. And it's unusual to find patients in TCA who have ventricular fibrillation or pulsus VT. So the median age of patients in this cohort who presented with a non-shockable rhythm, as you'd expect in TCA, were 43 years old. But there was a bunch of patients with shockable rhythms recorded as the first rhythm seen by EMS. And these patients had a median age of 63 years old, and they are statistically different populations. So there's something else going on here. And I include a picture of me in 30 years' time if I keep working in emergency medicine. So what we've got probably are some older patients who are presenting atypically and being included as TCA patients. And there's probably one of 3 things happening in these patients. It's either a cardiac event that leads to trauma that then is severe enough to be a traumatic cardiac arrest. They're patients who have a medical cardiac arrest secondary to the high injury burden from the trauma they receive. So young people are relatively capable of receiving a large trauma burden without going into cardiac arrest. But as you get older, of course, that becomes more likely. And the third group are those who have a primary medical cardiac arrest who then sustain some trauma. So a classic one for EMS is the older patient who has a medical arrest and then falls down the last few stairs or falls from standing, and they've got a bloody nose or a cut to their head, and they regularly come through and are reported as traumatic cardiac arrest. Clearly, what that patient needs is an ALS or ACLS algorithm. What they don't need are holes in their chest, 2 litres of fluid, and that isn't going to improve their day. Our biggest problem with traumatic cardiac arrest, and I alluded a bit to in my introduction, is that it's a really complex disease process that's multiple etiologies. And what we need, is a single way of approaching these patients because we need to do something quickly. But that is very difficult to do. So I've tried to conceptualise the different etiologies together. So I've got TBI, impact brain apnea, which is next to hypoxemia, of course, as well. We've got hemorrhage that crosses over into all those conditions apart from impact brain apnea. We've got tamponade that I've not even spoken about yet, so that's an important etiology of TCA. In the middle of these, we've got some sort of catastrophic, unsurvivable injury, even if you're in the world's best trauma centre immediately. We've got the medical patients who are probably older, or those who've had a medical event. So the questions you need to ask yourself are numerous. That is this a medical event, whether primary or secondary to a trauma? Do I need to oxygenate and bag them through an apnea, plus or minus some chest compressions to get some flow? Do I need to do a thoracotomy for a tamponade? That's really important. Probably is the most evidence-based, evidence-proven intervention in TCA in terms of survival. So in some centres, or in some series, that survival is as high as 20%. Or do you need to oxygenate them for hypoxemia? Have they got a pneumothorax that needs decompression? Or do you need to fill them up while controlling the hemorrhage? And at some point you need to ask yourself, is the patient dead? So that's a lot more complex than confirmed cardiac arrest, core 999, start chest compressions. So we need to individualise treatments, and we haven't really got a holding measure in the way that we've got CPR for medical arrest. So many of you will be aware of this, and this is the HOT algorithm, a really well thought through approach published a few years ago now to try and improve our approach to traumatic cardiac arrest. Although I find it hard to memorise this whole thing, and I'll come on to that in a moment. So this advocates early thoracotomy where the skills are available, and if not, for suspected tamponade from a penetrating wound to the chest, and if not, then rapid transport to hospital with the hope the patient's still salvageable. Also to consider a medical cause early, and if so, move across to the ALS algorithm. To then commence basic life support or ALS in all these patients with TCA. And then consider reversible causes, which are HOTS, hypovolemia, oxygenation, and tension pneumothorax. And then consider either transporting the patient who's got return of spontaneous circulation or terminating that resuscitation and leaving the patient at the scene. And what's good about this, of course, is that it gives you an algorithm to work not both in cardiac arrest, but also in that much more difficult peri-arrest situation and a patient who is about to go into cardiac arrest. But I find this, it's a great algorithm and it's well thought through. And if you have it as an aid memoir and someone else guiding you through it, then that's great. But we thought in the East of England that we needed something that was a bit easier to remember, some sort of mantra that we could use to remember the important reversible causes in TCA. So these are oxygenate, so either an endotracheal tube or an eye gel, probably more likely in the first instance, with some oxygenation and ventilation. Decompress with thoracostomies or needle decompression if that's your skill set. And fill, so start to volume load. And it's quite easy to remember oxygenate, decompress and fill as your immediate actions for traumatic cardiac arrest. Step 2 is control hemorrhage, which you might think is really weird. But these patients who are in traumatic cardiac arrest, it's quite unusual to see blood still coming from them. Obviously, you need to be a bit adaptable, so if you do see blood still coming from them, then you might consider retightening or asking someone else to slip a tourniquet on them while starting oxygenate, decompress and fill. But this includes checking and applying your tourniquets, thinking about pelvic binder, moving long bones into a better alignment, and potentially treating things like maxillofacial injury if you have the capability to do that. And then step 3, which is further interventions, thoracotomy, hysterotomy and chest compressions. Of course, you're going to move RT right up to above step 1 in patients who've got a suspicion for tamponade. And from what I said earlier, you need to consider the need for flow, and you need to be dynamic in your consideration for flow, and you might want to be doing that earlier as well. So let's have a think about how we might improve outcomes in the future for traumatic cardiac arrest management. So we've got a few areas. First one's epidemiology, engineering, enforcement, and education. So education is really important for us as healthcare providers to understand that traumatic cardiac arrest is not futile, and we can resuscitate some of these patients. And also to have really good SOPs. And also the ability to recognise traumatic cardiac arrest distinct from medical arrest, and hopefully also at a high level start thinking about the likely underlying causes or etiology of the patient in front of us. It's also really important for the public. I've shown you some data which shows you that in less than 8% of patients in a random sample from the east of England, they have qualified medical assistance within 5 minutes of arrival. I've got roads on there. I don't really know why. I don't think that improving engineering of roads is necessarily our bag. But medical innovation is also really important. I was going to talk about Good Sam, but it was covered at length last month by one of its inventor, who's Mark Wilson. And if you haven't got that on your phone, please have a look at it and spread the word. Our ambulance service now in the east of England is dispatching using Good Sam. And also in the realm of medical innovation, of course, are things like REBOA, SAP and ECLS, which I'm going to talk more about now. So let's move on to critical hypovolemia options for treatment. So I've already shown you this picture and this picture, so I'll go on to this one. So looking at cause of death series from the United States, this is from a number of papers that are put together, showing that hemorrhage is the leading cause of potentially survivable trauma death. So traumatic brain injury is slightly more prevalent than hemorrhage in causing in trauma death. But apart from what I said about impact brain apnea, there's not a lot we can do right now to improve that survival other than encouraging people to wear helmets, wear seatbelts and avoiding TBI in the first place. We know that tourniquets have massively reduced and been hugely effective for death from extremity hemorrhage to the arms and legs, and there's an 85% reduction in the military setting. So when we first went to Iraq, we weren't using tourniquets, and then during that period, they were reintroduced, having been used very effectively in the First and Second World Wars, but not so in Vietnam. And that leaves us with bleeding everywhere else, the chest, abdomen and pelvis. And if we look at some military data, we know there are 7,500 UK, US deaths in operations Iraqi and Enduring Freedom, which is Iraq and Afghanistan. We've got some good data from there because we include almost all patients. So we don't have this concept of patients not arriving into the trauma registry. And looking at those data, we can see that up to 90% of potentially survivable deaths were due to hemorrhage. And of those hemorrhage deaths, up to 2/3 were due to non-compressible torso hemorrhage, which is basically bleeding in the area shown on the slide here, together with a systolic blood pressure of less than 90 as a measure of shock, which we could have a debate about all night as to if that is a good measure of shock, but that's the definition. In this injury pattern, we see a 32 to 85% mortality. And I can hear you asking me, why is there such a broad range of mortality, Ed? And the answer is, I'll explain the concept around it, actually. So I've stolen this from the Twitter sphere, so you might have already seen it. But the US Navy wanted to know where it should reinforce its planes. So what it did was it did a splat map of all the planes that came back from combat runs, and it put these red marks on it to show where they thought the plane should be reinforced. And then this guy came along, who's Dr. Abraham Walt. He was a persecuted Jew in Central Europe, and he came over to the United States, and he was a very good statistician. So he said, well, actually, I'd expect there to be a random distribution of hits on these aircraft. So something's not quite right here. And then he realised that, of course, on the map that the US Navy had, these were the planes who were coming back from action. So these are all the places the plane could be hit and make it back. So they actually had to reinforce their planes in order to improve the numbers coming back from combat missions, was up front on the engines, the mid-wing section, and then, I don't know what this is called, the bit of the plane that connects the front to the back. And this is a really good real-world example of survivor bias. So the US Navy were only looking at their planes that survived to get back to base. And they missed all of that really useful data, which they couldn't capture, actually, but we could capture in our patients. So non-compressible torso hemorrhage. Almost all of the data only includes patients who make it to hospital to be included onto a registry, and then people like me can look at that data and make assumptions from it. The military is slightly different and has a much larger and more complete data capture, and that's why we know that from the military setting there's an 85% mortality from this injury pattern. We also know from military data that 90% of patients with this injury pattern were dead prior to arriving at a hospital. And from data that I looked at in the UK, even the patients who arrived to hospital, about 40% were either in traumatic cardiac arrest or approaching traumatic cardiac arrest when they arrived. But we haven't really made much progress in the management of non-compressible torso hemorrhage. So I'm going to show you a complex graph. Has anyone seen this before? No? Okay. This is the Bishop-Panbarwal rainbow graph, which is quite difficult to understand, so I'll just talk you through it. It's military data from Iraq and Afghanistan from 2003 to 2012. It's mathematical modelling of survival. What we've got here is the probability of survival up this axis. We've got the new injury severity score, which is similar to the injury severity score, the ISS. It's how badly people are injured. Interestingly, when the major trauma was first defined, it was defined as it is now actually, it's an ISS of more than 15, right? And they chose that because there was a 10% mortality at that point. And that was back, I think, in the mid to late 60s. So what we see in 2003, on the first line of this graph, we see that we're doing about as well as the definition of major trauma was in the 60s, so perhaps not amazing. But what we see over this period is that the 50% chance of survival moves from a patient with a NIS in the mid-30s to a patient who is really very severely injured. So this is really good evidence of an improvement in survival with much more severe injuries over that period. And I'm showing you this because we also have data on non-compressible torso hemorrhage survival in 3 equal cohorts, all of 99 patients from 2002 through 2012, thanks to Johnny Morrison. And what this shows is a trend of increasing survival, so up to the left. And they are small numbers with wide confidence intervals, which might be one of the reasons that we don't see a significant difference between these groups. But we don't see a significant improvement in survival from non-compressible torso hemorrhage over this period, despite the very clear message from the overall data of all the patients, which clearly shows an improvement in survival. So, what about options for treating this? So, the US federal government, in response to recognition early on in these conflicts of this injury pattern and its high mortality, instigated the wound stasis program in 2010, and Harvard Medical School tested about 1,300 foams, and they came up with the polyol and isocyanate phase foam, which is very biocompatible and expands up to about 40 times its original volume when mixed together. And this cool gun, which I can't wait to have attached to my HEMS flight suit. Hopefully it'll be smaller in future. So these foams have been shown to be removable in under a minute from the abdomen once the patient gets to, or the pig in this case, gets to hospital. We know it's quite effective in animal models, but there have also been some problems with bowel ischemia from increasing intra-abdominal pressure. A more recent study in human cadavers by Messer et al. Has shown that probably 65 mils is about the optimal volume in the adult human to be used as intra-abdominal foam. And this shows real promise. There's a trial that's about to start of in-hospital use in a trial of about 40 patients in the US called REVIVE, which is looking at it'll be the first look at how effective intra-abdominal foam might be in the setting of abdominal hemorrhage. So we very much look forward to those results. Of course, foam's is probably no good for pelvic hemorrhage, so it's really good for intra-abdominal hemorrhage if it works as planned, but not so good for pelvic. You'll be aware of what this is, probably some of you. This is an abdominal aortic junctional tourniquet. It's essentially a tight band that goes around your umbilicus, and it has an inflatable bladder which you can pump up, and it compresses down onto the descending aorta to occlude flow. actually first used, I think, in the early 60s to try and reduce the systemic exposure to chemotherapy, which I think is also where REBOA has also been previously used, or a version of it. We have animal studies, we've got some healthy volunteer studies. There's a single case report in the Journal of Special Operations Medicine that I'm aware of, but no sort of randomised trials or anything like that. It's really easy to apply with minimal training, so really good for kind of your average medic or perhaps EMS. I'd be remiss not to mention resuscitative thoracotomy. It's pretty ghastly. This is an open access picture I hasten to add from Google. So surgical opening of the chest was first described in 1874 by Moritz Schiff. It was actually first described to enable them to access the heart for internal cardiac massage, for medical cardiac arrest. And then later in the early 20th century, of course, there are those landmark papers looking at the opening of the chest in order to suture wounds of the heart and to relieve cardiac tamponade, which is a much more familiar indication to us now. It's really well established in penetrating injuries to the chest, leading to pericardial tamponade, and as I said previously, survival even as high as 20%, often a bit lower than that, but still some really good case series of high survival. It's got a dismal, probably less than 1% survival from blunt, in the setting of blunt trauma. And part of that's to do with the benefit-risk ratio, which I'll expand on in this talk in a few minutes, in that you need to wait for a patient to be in cardiac arrest and to be unconscious before you can open their chest, clearly. So most people now know what this is, but this specifically is a PRI-time ER REBOA catheter, which I think is being used in all the UK centres currently for the UK REBOA trial. It's got a couple of lumens on there. One says BAL, that's for inflating the balloon, and one says ART, which is an above balloon, very central invasive blood pressure monitoring port. And most people think this is a really new concept, but of course it was first described in clinical use in 1954 by a US Army colonel in Korea. And this is the Dr. Lucas balloon that he used. And it's often described that he used it in 3 patients. He didn't. The first patient was a patient in whom the catheter wasn't used, and the patient was later found to have died from a splenic artery injury. So a patient who was probably really amenable to balloon occlusion. The second patient had a catheter used. The blood pressure went from unrecordable to 110/70. And that patient later died, unfortunately, on the operating room table through multiple uncontrollable wounds. And this patient's probably in a low output state in trauma, hence the massive reaction, or the excellent reaction to that balloon being inflated. The third patient, the catheter was used. The patient was gasping with no powerful pulses, had an unrecordable pressure even after the balloon inflation. So this patient was probably in a no output state in trauma. So unknown to me until I read this paper, that's 60 or more years before I ever thought about the concepts of lost and nost. It had already been described, really. So over the next few decades, nothing really happened with balloon occlusion. There are a couple of series of reports for traumatic and medical causes in 1986 and 1989, but then the conflicts in Iraq and Afghanistan really increased the interest in non-compressible source of hemorrhage and what might be able to be achieved with intra-aortic balloon occlusion. And since 2011, through teams in Marseille, France and San Antonio, Texas, what we've seen is that in large animal translational studies, mostly pigs, that balloon occlusion increases survival, increases blood pressure, increases carotid flow, increases brain tissue oxygenation, has got less derangement physiologically than thoracotomy. And at this point, the term REBOA was coined by a collaboration of UK and US military surgeons. So, is it time for thumbs up and high fives all round? Maybe, maybe not. This is my very basic schematic of the aortic arch. So the heart is attached here, and this goes up to the brain and the arms, and this is the diaphragm. So REBOA involves insertion of a catheter from the groin, and then either up above the diaphragm or between the subclavian and the celiac axis for a zone 1 occlusion, which controls hemorrhage in the abdomen and the pelvis, or a zone 3 occlusion, which is essentially the balloon sits at the bifurcation, which is around the umbilicus, and that's used for control of pelvic or very proximal limb hemorrhage. So in zone 1, you insert a catheter, inflate a balloon, that controls hemorrhage. It also massively increases cardiac afterload, so the heart is suddenly pumping against a blockage. And this has either some theoretical or some known side effects. So that massive afterload will cause left ventricular dilation, which then stretches the myocardium, and that can lead to subendocardial ischemia. What that basically means is the heart is not receiving a blood supply. So a heart that's already struggling with this hemorrhage is struggling even further. That increased afterload also causes, or can cause, certainly in animals, frank pulmonary edema from the increased pressures. It can also cause ischemia of distal organs, so bowel and spine is important. In the animal models done a year before Hughes's initial report in Korea, some researchers used REBOA in dogs, and they said, and their conclusion was that the ischemic injury to the liver was so great that this will never be suitable for human use. And there's of course a chance of vascular injuries to inadvertent arterial punctures, and of course clot in vessels and distal ischemia resulting in limb amputation. When you deflate the balloon, there's also this ischemia reperfusion syndrome. So you're suddenly mixing this blood from parts of the body that haven't been perfused at all, or very poorly perfused for the length of the balloon inflation. And that leads to an acidemia, the release of pro-inflammatory mediators, vasodilation from those mediators, but also from the the CO2 release from those tissues. And those pro-inflammatory mediators, of course, can also worsen the lung injury. And this is all less problematic in zone 3 because less of the body is being occluded. So when I presented this, I used to talk about how these were sort of quite theoretical. Literally, in the last 5 days, this study has been published, which is a propensity scored, so retrospective study from the United States. What that means is they took 280 patients, first they took 140 patients who'd had a REBOA inserted in the emergency room of a US hospital. And they looked at all of the markers on their hospital charts in terms of things like age, their blood pressures, all that sort of stuff. And they matched them with 2 other patients who didn't have REBOA but looked very similar to the patients who'd had REBOA. They therefore matched them as best they could in order to try and compare 2 groups. 140 that had REBOA and 280 that didn't. What this showed was that those who had REBOA had high rates of acute kidney injury, which is probably not surprising. They also had high rates of limb amputation, which again probably isn't surprising. What you might expect, though, is that those that had REBOA required fewer blood products at 4 and 24 hours, but they didn't. So there was no difference in blood product use between the groups. What we're aiming for here with REBOA, though, is to stop people dying of hemorrhage, right? So we're hoping that there's an improvement in survival. So this is a survival graph, cumulative survival on the top. All the patients start at 1.0, so 1.0 is the whole cohort is still alive. 0 is that none of the cohort are alive, and then it's time across the bottom axis. REBOA is the yellow line, and the patients who didn't get REBOA is a grey line. So as we look at it, we're hoping for the yellow line to be above, because that would indicate that they have better survival, but it's not. So this study, unfortunately, in this group of patients, showed that REBOA was associated with worse survival. And you can see that that survival difference happens very early on, certainly in the first day of that patient's care. What they conclude, though, in this paper, I think is very sensible, which is there's a need for a concerted effort to define when and in which patient population REBOA has benefit, i.e. intimating that it might well be that that the results may be different if people had used the balloon at a different time or at a different point in the patient's clinical course, or if they'd used it in different patients than the ones who had it. So there's lots of advocates for balloon occlusion. I'm a balloon occlusion advocate, in case that doesn't come across. But then, of course, closer to home, this was some of our colleagues in NCCU's response to this paper, which is I predict that future medical historians will use REBOA as the best example of how bravado, social media and a culture of personalised introduction of new interventions combined to produce something truly harmful. So different ends of the spectrum. What we should remember is that all we have so far are case series and retrospective studies. So what has been emerging in the last few years is something called partial REBOA. So that's using partial occlusion, which allows some blood flow around the balloon and distal, which you'd expect would result in fewer problems. The smartest version of this has been used in some animal studies recently, and that's called endovascular variable aortic control. And essentially what that is either inflating the balloon or deflating the balloon in response to pressures above and below the balloon in order to provide the optimal perfusion distal to the balloon while still supporting the heart and still preventing hemorrhage. And Tim Williams and Austin Johnson over in the US have published a few papers now on EVAC. And what they've shown is automatic EVAC actually produces a higher blood pressure than complete occlusion with REBOA, and there's less derangement of the physiology which you'd expect with some ongoing perfusion distal to the balloon. And then more recently they've also shown that there's a reduced myocardial injury compared to complete occlusion, so it shows some promise. What we know at the moment is that zone 3 is less problematic than zone 1, but of course depends on the injury. If I'm bleeding out from my spleen, then clearly a zone 3 balloon is no good and I need occlusion higher up. Shorter occlusion times are associated with fewer problems, we think, and most experts in the field would now be a bit uncomfortable doing occlusions longer than 30 minutes. And endovascular variable aortic control is almost certainly superior to partial REBOA, which is almost certainly superior to complete REBOA. And this is an evolving situation as more evidence comes to the fore. The real elephant in the room, however, is how do I know that my patient needs REBOA at all? So on one hand, we know that early intervention in hemorrhage has better outcomes. So if I cut your arm off and you're bleeding to death, if I put a tourniquet on immediately, you'll do better than when I wait for you to be in traumatic cardiac arrest. It's just better to keep that circulating volume that belongs to the patient inside them. But we know that REBOA is not risk-free. And we know that some patients will survive without REBOA. And this is the patient who you're looking after, and they're sweaty and pale, and they have a blood pressure that's going down, but then it stays at 70 or 80 over 30 or 40, and they never end up crashing because they've either stopped bleeding or they've clotted off. But there's no way to predict that. So on the other hand, we know that late intervention has a worse outcome. So if you wait for someone to bleed into traumatic cardiac arrest, their survival is way lower than if you intervene, at a much earlier point. But later intervention gives you a better benefit risk. So if someone's in traumatic cardiac arrest, you know that they really need an intervention. But if they're not there yet, then they might not do, and the risk associated with it. But will REBOA, as probably our most advanced means at the moment in clinical use, still be effective if I wait in my patient for the benefit-risk ratio to improve? So how can we better inform this decision? So, using data. So the UK REBOA trial is recruiting at the moment. I think they've recruited 36. And it's running at a number of centres across the UK. And it's pragmatic in its inclusion. So the inclusion criteria are confirmed or suspected life-threatening torso hemorrhage, which is thought to be amenable to adjunctive treatment, i.e. REBOA. So this trial is obviously likely to answer some questions around REBOA use. It's unlikely to answer the question at which point in the hemorrhage spectrum we should be using REBOA, however. But obviously a very advanced trial that should be commended, and we'll look forward to the results of that eagerly. It's the first randomised trial of balloon occlusion I'm aware of, so a really important step in endovascular resuscitation. There's also the aorta trial, which is aortic occlusion for resuscitation in trauma and acute care surgery. It's a US-based registry looking at either thoracotomy with aortic occlusion manually or uses of REBOA. And again, that might produce some interesting results, although it's not random allocation. But really, we don't know, and we need more data. What we do know, of course, is that early femoral access is really important. I'll show you some data in a minute from Baltimore Shock Trauma looking at the significant difference in time to access the femoral artery in either hypovolemia or traumatic arrest from hemorrhage. And there's no doubt that early femoral access, as well as allowing you to have invasive blood pressure monitoring to look at your patients more accurately, it'll also make your life a lot easier when you decide to extend that treatment into a balloon occlusion. But what we really want is the ability to alter the risk-benefit in this complex decision-making process. And we want something either with fewer side effects or to have a later intervention when the benefit is clearer to the patient. Fewer side effects might be REBOA 2, REBOA 3, EVAC, or something like that. But what can we do about later intervention? So, unknown to us until they published the paper, the Japanese have been doing REBOA for quite a long time. And they published data from 2004 to 2011 in whom they had 452 patients who'd had REBOA. What they showed from this paper was that they had a odds of survival of 0.3, i.e. you were more likely to die if you'd had REBOA. And they had a similar methodology to that paper I showed you that was published last week, where they matched patients in their trauma registry of those who had REBOA against those who didn't but looked very similar. And this is their survival curve. But this retrospective data and matching is not completely clean. It's not a randomised trial. And so we should be careful when looking at it. And even the authors of this paper, in their conclusion, stated that it was likely REBOA was used in a last-ditch attempt in patients who were otherwise unsalvageable. So it's almost certainly not a fair comparison between REBOA and patients without REBOA. But this would give us a good example of what happens if you wait too long to control the hemorrhage with REBOA in your patient with non-compressive source of hemorrhage. So Baltimore Shock Trauma Centre in Maryland is arguably the world's most experienced endovascular resuscitation centre and a world-renowned trauma centre. Megan Brenner's published some more data from shock trauma recently. This included 29 patients with critical hypovolemia or severe hemorrhage and 50 patients with hemorrhagic traumatic cardiac arrest. And they published a few interesting bits of data, one of them being that the median time to access the common femoral artery was 141 seconds in severe hemorrhage and significantly longer, 300 seconds in patients with traumatic cardiac arrest. There was a 59% survival in the group who had REBOA in traumatic hemorrhage and a 10% survival in those who had it during traumatic cardiac arrest, which is significantly lower. What we also see from this data is that they undertook chest compressions during REBOA placements, which if you think back to what I said about an hour ago, it's been a long time, hasn't it? You might question that, and I don't know why they did that, but it's really interesting in this modern era in such a high-profile trauma system as to why they were doing that. The second one is that all traumatic cardiac arrest survivors had REBOA placed in the operating room, and that really poses two questions. The first one is uncertainty around the timing of this intervention. So even in a hospital that is amazingly well set up for REBOA, they still didn't get REBOA in the resuscitation room. They got it in the operating room later. And it might be that those patients moved very rapidly from the front door through to the operating room. And I don't know if that's the case or not. What it also says is that all REBOA traumatic cardiac arrest survivors were probably in a low output state in trauma, i.e. they were amenable to balloon occlusion, the heart was still beating, and when the balloon was inflated, they probably had a really good response and mounted a decent rise in their systolic blood pressure. Oh, I can skip over this, can't I? My apologies. And that. So what can we do to try and improve the later intervention? So this is the same schematic. Inflated balloon, we now know that this is called REBOA. And you can use a catheter which has a central lumen through which you can perfuse oxygenated blood or other perfusate up around the aortic arch, feeding the brain, importantly, and then importantly in cardiac arrest, going down towards the heart to perfuse the coronary vessels. And this is termed selective aortic arch perfusion, or SAP. And I was really lucky to work with the inventor of SAP, who's a really great guy, Jim Manning, up on the left there. And we did this together with Dr. James Ross, who's a trauma physiologist in his lab in San Antonio, Texas, but he now works at Oregon Health and Science University. The SAP catheter looks like this, a bit like a REBOA catheter. This one is one from a few years ago as an experimental catheter. And you can see a syringe on there to inflate the balloon, and then a larger high-flow stopcock, which is connected to the end of the balloon through which you can pass oxygenated blood or fluid. And I could get at least 1.6 litres of threshold blood a minute through this catheter without significant hemolysis. So it looks quite small, but you can get really high flow rates through there. Took a large pig model, 70 to 90 kilo swine, removed their spleen because they're massive and auto-transfuse in injury, marked the left lateral lobe of the liver with electrocautery for subsequent injury, and then let them rest for 10 minutes. All these experiments were carried out under appropriate animal use ethical clearance. What I then did was excise about 70% of the left lateral lobe of the liver under laparoscopic conditions with Metzenbar-Mendo shears, and you can see it's a mixed arteriovenous injury. And then 5 minutes after that, I controlled arterial bleed to get a really severe model of hemorrhage. So the model was an intra-aortic blood pressure of less than 10 millimeters of mercury and a relative bradycardia. So that means the heart's got faster through hemorrhage, and it gets to a point where it can't beat any faster, and you start to get bradycardic. So this is heading towards electrical asystole. This was sustained for 3 minutes, and during that time, 1/3 of the animals went into asystole. So a very severe, no output state in trauma model of hemorrhagic traumatic cardiac arrest. There were 4 groups. CPR group had some fresh whole blood and chest compressions. The REBOA group had a REBOA and some fresh whole blood. The SAP lactated ringers, which is like Hartmann's group, had 1,600 mils of oxygenated intra-aortic lactated ringers through the SAP catheter, and then up to 7 250 ml boluses if they had a systolic less than 90, and then a 4th group of SAP using oxygenated fresh whole donor blood from other pigs. And the primary outcome was 60-minute pre-hospital survival. So the median time militarily that we had was about 60 minutes, and that's not dissimilar to the civilian statistics on pre-hospital time for non-trapped patients, about 60 minutes. So what we showed was that the first opportunity to declare the animals were dead, all the animals that had REBOA were dead, and that was expected. So it's a no output state injury where the heart's not really beating. So you can do as much occlusion and filling as you like, but the heart's not going to start beating on its own again. The CPR animals, unexpectedly, did slightly better, although not very well. And then SAP with LR, better again. SAP with fresh whole blood did really well. And actually, all of them had a return of spontaneous circulation, but one had some unusual liver anatomy that caused a very central, rapid hemorrhage that wasn't amenable to even SAP. You can see that these have different survivals, and statistically, SAP with fresh whole blood was significantly better than the other interventions. Importantly, what we also showed was that SAP with fresh whole blood could resuscitate even electrical asystole secondary to hemorrhage, which is most commonly thought to be an unsurvivable event. So, SAP might help us in our risk-benefit analysis of endovascular resuscitation by changing some of the risk-benefit ratio by allowing later intervention to fall back on that can resuscitate more severe states of hemorrhagic traumatic cardiac arrest. And I'll explain that with the next small group of animal studies. So the same model with 8 large pigs bled them down to the same arrest criteria and left them for 3 minutes. And all of the animals received a zone 1 REBOA treatment, so a balloon and 4 units of fresh whole blood via the external jugular vein. And really unexpectedly, 2 of them had a return of spontaneous circulation. And you see the blood pressure in that group is 160 systolics. They mounted a really strong response. And what this tells us is even a lab with loads of monitoring on a patient in a really controlled environment, having done tens and tens and tens of pig traumatic cardiac arrests, we still don't know when REBOA and filling might be effective in these severe states of traumatic cardiac arrest, even in the lab. So imagine how difficult it is in the clinical setting to work out at what point REBOA may be best used. In the 6 that didn't get a ROSC, they had the failed REBOA protocol, which was passing oxygenated blood up a SAP catheter, perfusing the brain, which is probably a bit hypoxic by now, and feeding the heart. And this is termed rescue SAP. At 800 mils a minute. So these 6 animals got a rescue SAP treatment. 2 of them had a return of spontaneous circulation and 4 didn't. In the 4 that didn't, accessed the inferior vena cava, inserted a large venous ECMO cannula, pumped that round into a CardioHelp, which is a sort of a very portable ECMO pump. And for those people who are here later, I've got some photos I can't show with the live feed, but I can show you some photos of that kit and some videos of it. That blood gets pumped back round, oxygenated up the SAP catheter and round, and that goes round and round and round. So the pig's already filled up with all the blood we've already given them. So what we need to do now is circulate and get flow. And this is termed SAP ECLS, 800 mils a minute, which is about 10 mils per kilo per minute, which is about what you get as an 80 kilo human. So these 4 pigs got SAP ECLS, which of course also perfuses the brain, and they all had a return of spontaneous circulation and survived the prehospital period. And I know you're itching to know what happened to the other 2 groups, and both of them also survived. So what we think we showed with this protocol was the ability to potentially intervene later in the spectrum of hemorrhage to alter the decision-making process around the use of endovascular resuscitation, but having a fallback option of escalating through sequential modalities from early arterial access through REBOA, through rescue SAP, through SAP ECLS.
Is this purely looking at physiological survival as opposed to neurological survival?
Yeah, that's a really good question. So none of these studies looked at neurological outcome. So the animals are anaesthetised and don't wake up for animal care reasons. So we can only hypothesise as to how their brains may have been after this, and that might be the limiting factor in the ability to use this paradigm extremely late on in hemorrhage. But of course, in the lab setting, with a relatively quick injury, what we are hoping might be the case is that in patients who are initially unresponsive to REBOA and filling, whose hearts have had a longer period of ischemia, that SAP will be a useful adjunct to kickstart that heart and improve its contractility. Yeah, that is a good question. One of the benefits of SAP, of course, moving from REBOA, is that I haven't got the graph with me, but we did carotid flow, so you can see the flow up to the brain during the experiments as well. And what happens, of course, at this period where you start the rescue SAP, you see a blood pressure going up, but on the carotid flow, you see a massive spike in carotid flow. So as soon as you start rescue SAP, you're getting probably supranormal, i.e. higher than they would regularly getting oxygen flow and blood up to the brain. So my take-home points are that NCTH is important, but we don't really know the epidemiology, which is crucial to understanding how we might improve patient outcomes in the future. We know that endovascular resuscitation is rapidly developing, and we probably need some better data, and hopefully UK REBOA will give us some of that to make better decisions about endovascular resuscitation. And the decision-making might be improved through intervention with lower risk, so things like AHAT, the development of intra-abdominal foam, and probably some more advanced REBOA devices like EVAC. But also might be improved through thinking about the possibility of escalating intervention, i.e. early arterial access, and then moving through that sequence of interventions I've described in the animal lab. So overall, what does all this mean? I'd like to leave you with the mantra of oxygenate, decompress and fill, brackets plus minus CPR, for you to take away as a concept in your head for the immediate actions on traumatic cardiac arrest. We also need better data on TCA, and we need to individualise treatment and think of ways that we might be able to do that. Education is really important. And endovascular resus, I've said may have a part to play. It almost certainly does have a part to play in the management of these patients. And last but not least, that TCA resus is not futile. I've almost certainly overstayed my welcome, so I will stop talking there. Thanks very much. I can take questions. I think we've got some microphones as well, so those at home should be able to hear.
Thank you. Just almost picking up on your last slide about education of public. You know, in your pigs, they got REBOA within 3 minutes of arrest or whatever, but in your other chart, it showed about 10 minutes for East to get on the scene. Like, what do you kind of educate the public to do? Just continue with their BLS teaching, or what?
Yeah, that's a really good question. And one of the problems we have when talking about traumatic cardiac arrest is that it's not even that we have a consistent message across healthcare providers' education. It's that we also need to, of course, encompass the really important part of this process, which is, buddy aid from members of the public. And one of the real risks I see with the de-emphasis of chest compressions in traumatic arrest is what do the public do when they come across a traumatic cardiac arrest? And there's no way that we can expect them to do the interventions that we think are potentially treating reversible causes such as hypovolemia or chest injuries. And there's also that subset of patients who've had an impact brain apnea, and we've no idea how big that proportion of patients really is. And those patients, are extremely survivable with really high quality bystander CPR. And so I think at the moment what we do is we tell the public to continue to do bystander CPR, and we also try and teach them about hemorrhage control with the use of tourniquets and pressure. Does that answer your question? Good.
I was wondering if you could shed some light on some experience with lifting the legs as the patient's in arrest, obviously to sort of reduce the amount of venous return and get some volume back up into that sort of thoracic cavity.
Yeah, so that has been. So I'm in no way expert on that. But I'm aware that there's been a resurgence of interest in that manoeuvre. I'm not aware that anyone's published improved survival outcomes from that technique. But more than that, I can't tell you. It would seem to make sense, wouldn't it? So things like the impedance threshold device and the way we think about trying to increase venous return and preload. You'd think that in medical cardiac arrest there would likely be some sort of benefit from that, but I don't. I think in the studies to date there has been no improved outcomes demonstrated.
I'm getting all the work this time.
Thank you. Is anyone looking at aortic tourniquets? I was chatting to the bloke who sells them yesterday at the EHAC conference thing, and he's obviously a great advocate of them. I think there's a sort of sample group of one from Bastion, maybe, for their use. So is anyone looking at them? You mentioned them earlier on.
Not that I'm intimately involved in, but we do need a study that compares the use of REBOA, the AHAT, and intra-abdominal foam, which includes a look at which level of providers, both militarily and in the civilian setting, can reliably be trained and maintain the skill to deploy those interventions against their efficacy in the lab. And that's going to be a really important study or studies going forward. And what I'm really getting at from my perspective militarily is that there's a lot of interest in REBOA, and there's lots of people who would like to be trained in its use, when it might be more suitable for them to be deploying the AHAT or maybe foam, depending on what that what the studies show. So when you're thinking about the risk benefit, the burden of training, the ability to maintain the skills, and the likelihood of iatrogenic complications, then foam looks like a really great therapy. And for hemorrhage further down, we know that you can put an AHAT on and effectively occlude the aorta, in a few minutes, pretty effectively. But as far as I'm aware, I don't know anyone who is looking at that right now.
Because the Army military doctrine of Level 254 MedReg, which is a TA, Regiment Army Reserve, whatever they're called this week, they're very much doctrinally trying to move away from high-tech medicine back to here's a tent, go and do some stuff that injured people. And that sort of aortic tourniquet seems to be quite a useful thing in a very specific number of abdominal injuries.
So I'm not sure it's terribly effective for abdominal injuries. I think it's really useful for injuries distal to the abdomen.
Yeah.
So we don't really know, but the manufacturers or the designers suggest it would be useful even in pelvic hemorrhage because it might hold the body together.
Yeah.
It seems to me like it might cause some problems as well in some patients, but it's really designed for occluding the aorta distally in order for those proximal sort of blast type injuries to the
So
limbs.
it wouldn't be any good for sort of gunshots to kidneys and liver and stuff, but that lower level damage to pelvis specialists, which traditionally we've always struggled to deal with.
Correct. Yeah.
Pre-hospital.
Yeah. So it's too high for tourniquets.
Yeah,
Yeah.
exactly.
Yeah.
Exactly.
Going away from Mike.
So you were saying about too late for, or trying to get REBOA in late. How late is late? We're bearing in mind how long it's going to take the ambulance service to get to the patient and then get them to the nearest trauma centre. Because as you know, in this area we've only got one trauma centre, being Addenbrooke's.
Yep.
So if you're up at somewhere like Leiston, you're not going to get them to a trauma centre. Are they
I don't know
looking at the air ambulance, doing more REBOA stuff?
So that's the golden question: is which patients and when. And I don't think anyone knows the answer to that. Now, at the moment, so the UK REBOA trial is obviously using REBOA in their study in a hospital setting, and I'm sure there are lots of reasons for that. But you wouldn't necessarily consider doing a trial of arterial limb tourniquets only in hospital. I can't think of the last time I put one on in a hospital. As in the hemorrhage has happened before you get to hospital. And if you get to hospital alive, then you might consider there's probably less of a need for that hemorrhage control adjunct, or you'd hope there would be. Now, there are some situations, of course, where you'd be in a situation where you have more than one patient requiring surgery, and only the possibility of doing surgery on one patient at a time, where you might use REBOA in hospital to hold one patient while the other patient is operated on. I don't think there's any suggestion that we're about to start REBOA pre-hospital in the East of England, and that might happen at some stage in the future. One of the problems, of course, as well, is that we're pretty sure that with the current complete occlusion REBOA, the consensus for the total length of occlusion is about 30 minutes. So there's not a lot of time around the East of England to occlude somebody and then get them to Addenbrooke's, and then enough time to get into theatre to get hemorrhage control to then remove the balloon. But it's not enough time.
I was going to, it's not actually about traumatic cardiac arrest, but when you were talking about chest compressions in a hemorrhagic situation, so it started my brain thinking, so in a maternal, especially in catastrophic hemorrhage, which happens maternally, they go into cardiac arrest, they do chest compressions. Should they be changing their attitude and actually push the filling before the chest compressions in that sort of situation?
Yes, probably.
So do we need to speak to Resource Council?
Yeah, last time I read those guidelines, there were lots of things in there that seemed to be sort of one iteration of guidelines behind that of the non-obstetric guidelines, if that makes sense.
Yep.
So still advocating the use of 2 litres of crystallise, which might have more of a place in obstetrics due to the difference in physiology of the term mum than the non-pregnant patients. But yes, quite possibly. Okay.
Yeah, there was just one more. That was, how much volume do you recommend giving before starting compressions?
Ooh. I mean, again, that's a really great question, but one that you just can't answer, and there is no one size fits all. So I've not got an answer to that question. It's all about, so part of my aim for this talk was to arm you with a kind of deeper understanding to conceptualise what may be happening in your patient's intraumatic cardiac arrest, in order for you to be able to make these decisions dynamically in the individual patients who you treat. And so I've got no answer to that question, apart from some. Really? Yeah. Anything else?
So, just like to say a huge thank you to Dr. Barnard tonight. We've had a fascinating talk, lots and lots of things to learn from, reflect upon, take back into our practice, and we really appreciate you giving up your time and talking to us tonight. I think, speak for everybody here, it's been absolutely fantastic. Thank you so much.
Thank you.
So as usual, if you go to the URL, tiny URL, and fill in the feedback, we'll be able to then send you your certificate for your CPD. The date for the next forum is Thursday the 18th of July, and we're going to be covering extrication. We've got a couple of great speakers lined up for you. We'll put more details on the Facebook page over the next week or so, so look out for that. But thank you all again for coming, and thank you to those watching via the live stream.